Uh, we now take up the next talk about combining topography guided surface ablation with cross-linking. So basically, like Dr. Vavikar explained, cross-linking was a method, the conventional cross-linking was a method to strengthen the cornea and to prevent the further progression of keratoconus. But the problem here is, even after cross-linking, these patients very often have a very high cylinder, and with the amount of aberrations, and the quality of vision is very poor, and therefore these patients are not able to use normal glasses or even normal contact lenses, and not all patients are affording to go in for a scleral contact lens. So basically, combining a TPRK, that is a topo-guided PRK, with cross-linking really helps in smoothening the cornea so that these patients can be not only corrected of their aberrations, but also a fair amount of the cylindrical errors can also be corrected within the safety margin. So we first had the cretin protocol, where what happened is the epithelium was removed by a topographic guided PTK at only a 50 micron level in a 6.5 to 7 millimeter optical zone, and this was followed by the corneal collagen cross-linking. We then had the Athens protocol by John Kanellopoulos, where the epithelium was removed by PTK, followed by a topographic guided ablation to correct the micro irregularities, and followed by the cross-linking. And then we had the group from Narayan Netralaya, which did the study on manual epithelial removal, followed by a TCAT treatment with the Wavelight Allegretto platform, and that helped in smoothening the cornea with a maximum stromal ablation by the excimer laser of not more than 40 microns in the thinnest corneal region. So basically, who all can benefit from this procedure? Mild to moderate keratoconus, patients with thinnest pachymetry, which is more than 450 microns, patient with poor contact lens fits and were unhappy with glasses, patients with no active allergic eye disease or no active ocular inflammation, and no central scarring. So there are basically today, there are two planning stations which can be used for this, the Alcon Wavelight EX500 or the Schwind Amaris, and I'll be talking more about my cases on the Alcon Wavelight EX500. So I would like to present a few cases. This was the first case, a 28-year-old female with thinnest corneal thickness of about 518 microns with a grade 1 keratoconus. This was the pachymetry, the pentacam maps. As you can see, even the bad D was bad. And this is the pre-op topolizer scan, which is important to treat this patient on the Wavelight platform. So coming to the planning over here, what we need to understand here is we first make the modified refraction on the Wavelight platform to be 0. Having done that, we see what is the maximum ablation. So without any refractive correction, we are correcting about 11 microns in the central region just to smoothen off the aberrations of the topographic cornea. Again, the optical zone is kept between 6 to 6.5 millimeters depending on the position of the cone. The epithelial thickness is checked out from the AIOC2024 and then is fed into this. And then we go to a Zernike's equalization, where we try to match the C12 to the C4. Now here in this particular case, the amount of the Zernike's spherical equivalent which we need to correct is a very small amount, and since we are not correcting the sphere in this case, it can be as good as negligible. So after C4, C12 combination, compensation, we are just modifying the refraction by a minus 0.16. Now, what is most important here is to check what is the residual pachy before the ablation. So that is about 438 microns in this case. Now here, if you can see that the patient was accepting a cylinder of 3 and the topographic cylinder was 2.75. So we go with the 2.75. Most important thing is always treat, since we are doing a TPRK, that is a topo-guided PRK, always treat the axis as per the topolizer. And now, again, here it's important to check what is the residual cornea after we would have ablated, because this is important, because the type of riboflavin which you will use depends upon the residual stromal bed after the ablation. So here, since it is more than 400 microns, we can go with the isotonic riboflavin in HPMC. We have stopped using Dextran now. So this was the final treatment. We did an alcohol-assisted epithelial removal, went ahead with this treatment with the Dresden protocol. And this was a topolizer scan after 1 month. So we can see that the cone is very well centralized even after 1 month. And this is the comparative map, as you can see. the pre-op and the post-op. And there is a change right at the 1 month stage in the steep K by about 2.5 diopters decrease. The astigmatism from 3.75 had come down to 1.5 diopters, and the best corrected visual acuity is same. So we're not losing any line in this particular case. In this second case, again, a grade 1 keratoconus with a thinnest point as 560. Again, this is the topologizer scan. The planning remains the same. We check for the ablation. Now here we have gone with the patient's measured topographic cylinder was about 5.77, but then that would not give us enough residual stroma, and we can't go in more than 50 microns in the center. So as can be seen over here, the central ablation should not be more than 50 microns, and therefore we have gone with the patient's acceptance of 2.25. And this is the final correction. And again, the residual stromal bed is 458, so we go it with the isotonic solution. This is a 3-month scan. Again, here the steep K has decreased by 1.5 diopters, astigmatism has decreased by 1 diopter, and the patient's refraction is improved from 618 to 69. A third case, again a 22-year-old male patient with a cylinder of minus 2.5 diopter, grade 1 keratoconus. These are the pre-op pentacam maps. This is the pre-op topologizer maps. The planning again remains the same. I'm not going to go through the details again. Again, here we have gone as per the, in between the topographic cylinder and the patient's acceptance. We have gone a little over 50 microns, but again we had a good residual stromal bed, so we went ahead with this particular treatment. And this is a scan. This is a patient we have the scans for the longest time. This is a 1.5 years old scan, and here the steep K has decreased from 43 to 42.3. The change in astigmatism has come down by almost 2 diopters, and the best corrected visual acuity has come to 6.6. This is another one case where this patient had a combination of a sphere and a cylinder. He was improving only to 612. Grade 2 keratoconus. This is pentacam maps. The pre-op topologizer scan. Now in this particular case, we checked for the residual ablation, and we are correcting only 17 microns with a 0 rule. And here there's a lot of difference between the patient's refraction and the topologizer cylinder. Topologizer cylinder is much lower than the patient's acceptance. So there could be a lens element in play, and therefore we are going in almost as close to the topographic cylinder, and therefore we're correcting about a 1 diopter cylinder in this particular case. Again, if you see here, the residual stromal bed would be only 390 microns, and therefore this is a case where we had to use a hypotonic riboflavin. So what, like Dr. Vavikar explained, what do we do if the cornea is thin? We can use a contact lens assisted treatment, or we can do a hypotonics, this thing, or we can use the Hafizi's protocols where we can change the amount of fluence and the time of irradiation for different corneal thicknesses. So this is a good chart which is published by Narayan Netralaya, where you can see the various thicknesses. So depending on what is your residual stromal bed, and depending on whether we are using a 3 millivolt or a 9 millivolt accelerated cross-linking, the amount of time for irradiance is defined. And they also have a nice calculator over here where we can keep changing the thickness, and we get to know the amount of time which is required for that particular case, for that particular thickness. So that particular patient where we used the hypotonic solution, so this was his map 6 months post-op. Again, his steep K had decreased, his astigmatism had decreased by almost 1 diopter, and the patient from 612 improved to 6.6. This is the last case, again a 22-year-old with a grade 1 keratoconus. Now in this particular case, we decided to use, and we are using more and more of this, of the streamlined procedure, that is the epithelial removal by a transepithelial removal. The advantage of this is the the epithelial removal by the streamlight takes into consideration the keratometry value, and therefore the removal of the epithelium is very regular. However, they don't have a link of the streamlight with the TPRK, so therefore what we need to do is we need to feed this as two separate treatments. In the first treatment, we have just fed a small negligible sphere of 0.25, otherwise this would not go ahead. And we stop this treatment right when the epithelium is removed. So we don't allow that 0.25 to get treated. And having done that, we do a second planning for the TPRK as was explained before, with the same safety features. And this is the patient's 7 months post-op scans. Again, you see a significant improvement, centralization of the cone, and a great improvement in the best corrected visual acuity, right from 615 to 66 partial, and uncorrected vision of 6 by 7.5. So what does this procedure add? Basically, it increases the corneal biomechanical stability. It flattens the apex of the cornea and also centralizes the cone in most cases. It helps in decreasing the mean spherical equivalent, and at the same time, it causes a regularization cornea, gives you a better quality of vision, and the most important thing is a better tolerability to normal soft contact lenses. Patients do not need to go in for the more expensive scleral contact lenses. I'm sure Dr. Quresh is going to be angry with me for having stated that. Thank you for your kind attention.